So we're not yet done with the apical window. We learned what happens when you tilt the transducer. Now it's time to take a closer look at the rotational movement of the transducer. We'll look at the two-chamber view, the three-chamber view, and then we'll look at a special view which we call the lateral view. Let's take a look at the two-chamber view first. Many people, especially at the beginning, have problems to display the two-chamber view. Now, traditionally, the way you would find it is that you start with the four-chamber view and then rotate counterclockwise. If you do this, it's very important, however, to have the maximal length, so no foreshortened ventricle in your field of view, and to place the ventricle really in the middle of the screen. When you rotate, fix the transducer so that it don't slide away from the position, and also don't change the tilt. You can control that, however, by looking at the size of the left atrium. Let me display that. Here is the four-chamber view. Now I'm rotating counterclockwise. If I, for some reason, change my tilt, I will also lose the left atrium. So while you're rotating, always check for the size of the left atrium and correct by tilting in such a direction that, again, you will have the left atrium in your field of view. When do you reach the two-chamber view? Well, obviously, you're not going to look at the angles. You're going to look at the image, and you're going to find the two-chamber view as soon as you do not see the right ventricle anymore. So in this case, there is no interventricular septum, and you know that on the right-hand side, you have the anterior wall, and here is the inferior wall. A few other very important anatomic landmarks are the left atrial appendage that you will frequently see here in a two-chamber view, and the coronary sinus. With a little bit of tilt, you can sometimes also see the descending aorta. Let me display that. Tilting a little bit, often you lose the left atrium here. You have the descending aorta right here in your field of view. So, in essence, it's not difficult to find the two-chamber view if you adhere to these few tips. Now let's take a look at the two-chamber view, this time not in a patient, but on the simulator. If you want to get to a two-chamber view from a four-chamber view, it's first of all very important to bring the left ventricle into the center of the image. Once you've achieved this, you rotate counterclockwise, and while you rotate, you try to also observe the size of the left atrium. Never lose the left atrium, otherwise you will not get into a good two-chamber view. So adapt the tilt so that you always have a two-chamber view, and then you rotate until you lose the right ventricle. In that situation, you are then in a two-chamber view. Now, there is a slight variation of the two-chamber view that you should know as well, which is the commissural view, and that is usually a little bit less rotation than the two-chamber view. If you have the commissural view, you will not be able to really differentiate between an anterior and a posterior leaflet. This view, however, is very important if you want to detect the origin of the jet. Here you would have the anterolateral commissure. This is the posterior medial commissure, and these would be the middle portions of the mitral valve. If you go back to the two-chamber view, what different portions of the ventricle do you see? You have the anterior wall here and the inferior wall right here, and this would be the apex. Very important also, in a two-chamber view, you usually see much more of the apex than in a four-chamber view. What structures are you going to see? Let's summarize. We have the left ventricle and the left atrium. We don't see any other chamber. We have the inferior wall here on the left and the anterior wall here on the right. In the two-chamber view, you will usually see less foreshortening, and you can look at the left atrium, and sometimes it's even possible, as not displayed in this graphic here, to see the left atrial appendage, which would be somewhere in this region right here. What is it good for? Again, to look at global left ventricular function together with all the other views that we've shown you and will still show you. We'll look at regional wall motion abnormalities. Obviously, we'll look for inferior infarcts here in the inferior wall and anterior infarcts here in the anterior wall. We'll look at the degree of mitral regurgitation here. Even though we do not see the anterior and the posterior leaflet as well, or at least we don't see the motion of these leaflets as well, we do see regurgitation here and can image the patient along the line of closure. This will be a very important topic when we discuss mitral regurgitation. Of course, it's also important to look at the severity of MR in this view as well. In the lecture on the basics of imaging, I already mentioned that respiration can sometimes help you, especially if you want to image the anterior wall or also the inferior wall in the two-chamber view if you use respiration. Here's again is a demo that shows you how you can use respiration to your advantage. Sometimes the patient have better image quality if they inhale. This is especially true for the two-chamber view, and I'll try to demonstrate that here. This is a patient who has moderate quality of the two-chamber view, and I will now ask the patient to inhale. Können Sie mal einatmen? See, and immediately we get, das ist zu viel, ein bisschen ausatmen. We get better image quality. Sometimes he should not excessively inhale, as in this case, but if he inhales moderately, you can see the anterior and the posterior wall much better. By rotating the transducer another 60 to 80 degrees further counterclockwise, you'll come up with the so-called three-chamber view, which is also called the apical long-axis view. The classic way to get to a three-chamber view is to rotate counterclockwise even further from a two-chamber view. Let me show you this first, and then I'll show you another approach which I actually find a little easier. This is now the two-chamber view, and now I'm rotating counterclockwise even further without losing contact with the body and without tilting until I get the aorta, the LVOT, and the papillary muscles into my field of view. So in this case, I get a very nice three-chamber view. However, very frequently it will be difficult to stay in the axis, especially if the intercostal spaces are not oriented perfectly to the orientation of the three-chamber view. In reality, it's very simple actually to just use a one placement strategy to demonstrate the three-chamber view. How do you do that? Well, take the transducer and put the thumb on the marker and point the marker to the right shoulder and simply place it on the chest. There you have it. This is the three-chamber view without using the rotation technique. I actually find this a lot easier. The disadvantage here is that you do not scan the region between the two and the three-chamber view. So both approaches can be used combined. Now let's take a look at what we actually see in the three-chamber view. As already mentioned, we have the aortic valve right here with the flow across the aortic valve. We have the LVOT. This here is the left atrium. Right back here we have the descending aorta, and we have the posterior leaflet and the anterior leaflet with the chordal structures, the subvalvular apparatus, and the papillary muscles. So this is a view which is very good to assess, for example, mitral regurgitation and restriction of the leaflets. But this will come later when we talk about the mitral valve. Next, I would like to turn to the simulator to show you again which structures we see in the three-chamber view. By further counterclockwise rotation, you would get into the three-chamber view, or the so-called apical long-axis view. What structures do you see here? Well, pretty much the same structures that you would see in the peristernal long-axis view. Again, we have the aortic valve right here, the mitral valve with the anterior leaflet here. We even see the coronary sinus. We see only part of the right ventricle, so this is not the best view to actually look at right ventricular function. And we have the interventricular septum and the apex right here. Now, if you tilt the transducer a little bit, then you will see a view that is very infrequently performed, but which I think is very helpful if you want to look at the tricuspid valve. Take a look at this view. This is the tricuspid valve, and here you will very frequently get a very good signal if you want to quantify pulmonary hypertension. To summarize the apical long-axis view or three-chamber view, here are the structures that you can appreciate here. You'll see the left ventricle, the left atrium, the left ventricular outflow tract, the aorta, and also some parts of the right ventricle, as well as the aortic and the mitral valve. Where can you use the three-chamber view? Well, basically, it's for the assessment of wall motion abnormalities, just as all the views are that I've shown you so far. Only that in this case, we're now looking at the posterolateral wall and the septum. Here in this case, you see an infarct in the posterolateral region. You can see the left ventricular outflow tract and also the aortic valve, and therefore I detect pathologies such as an aortic valve stenosis, aortic regurgitation, or some form of LVOT obstruction. Here's now an example with color Doppler. Here you will see aortic regurgitation. In this case, also a little bit of mitral regurgitation. So you will be able to look at the function of the valve, both with respect to whether or not they're stenotic or incompetent. You've probably noticed that the apical long axis view is very similar actually to the peristernal long axis view. We're imaging through the same structures actually. The only difference is in the apical long axis view, we do see the apical structures here. We do not see them here in the peristernal long axis view. In contrast, in the peristernal long axis view, we probably have a better appreciation for the aortic valve and the mitral valve because we're simply closer to the transducer. So use both of them, but remember that both of them show you basically the same myocardial segments, the septum and the posterolateral wall. When you put all this together and you look at the different orientations we have and track them on a short axis view, you will see that with these views, they're rotating around the left ventricle and looking at different regions of the myocardium. For example, in the two-chamber view, you would be looking at the septum and the inferior wall, while with the apical long axis view, you're cutting through the anterior septum and the posterolateral wall. So in summary, all these views are important to get a full appreciation of the entire ventricle. But remember, you're not seeing these structures here and these structure right here if you're not moving the transducer continuously from one of these views to the other. That's why it's so important to not only perform the standard views, but also to look in between. And one such view which really gives you an appreciation of a very important region is the so-called lateral view. And let me show you how this is done in the following demonstration. Remember, you're in the master class, so I'm going to show you some views that not everybody knows. This is a special view that I use to display the lateral wall and also to examine patients with aortic regurgitation. How do you get this view? Well, you start from a four-chamber view, and then instead of rotating towards the two-chamber view, namely counterclockwise, you rotate clockwise. Now see what happens. All of a sudden, you will get the aortic valve in your field of view. Now this is not a classic five-chamber view. I'm not tilting, I'm just rotating. And by rotating, I also have the aortic valve in my field of view. In this view, I will be seeing different portions of the left ventricle. I will actually see more of the lateral wall here. And I also see different portions of the aortic valve as if I would perform a five-chamber view. This is the view that is usually optimal to investigate patients with eccentric jets of the aortic valve regurgitation. So remember this view and use it in the setting of aortic regurgitation and if you're looking for a lateral myocardial infarction. So the atypical lateral view is somewhere right here. It's kind of an over-rotation from the apical long axis view, and what you're seeing here are the regions which are kind of between the anterior and the lateral wall that you see in a four-chamber view. Here again is the normal five-chamber view where you're seeing the aorta, and this is the atypical lateral wall where you're also seeing the aorta. But remember, you're getting the aorta not by tilting but by over-rotating so that a part of the sector now rotates into the aortic valve. So on the first look it might appear the same, but it truly is not. Here you're seeing different parts of the myocardium as you are in the classical five-chamber view. What is it good for? Well, basically it's very important if you want to look at infarcts in the lateral wall, to look at regional wall motion abnormalities, and it's also a beautiful view to look at aortic regurgitation because in this view you will nicely see the eccentric jets that are often present in patients who have some form of aortic valve pathology. Finally, I want to take a look again at the supraapical view. We saw that view already when we looked at the peristernal view. Why are we showing this again? Well, basically because it's a kind of a hybrid view between a peristernal, I would say, short axis view of the ventricle and a supraapical view, because all we're doing is we're moving in a short axis view just further down to the apex to cut through the supraapical portions. So as a short review, here again is this view where you're seeing a rather small ventricle. This is the cut plane where you would detect, for example, an apical thrombus, maybe an aneurysm, or even wall motion abnormalities. And one thing that has also been looked at is the rotational motion of the apex, which can be indicative of a dysfunctional left ventricle. Finally, there are some views the so-called long axis views of the right ventricle, which are also not standard views, but which can be helpful if you want to assess right ventricle function. For example, there's the so-called inflow-outflow view. Here you see the inflow of blood through the tricuspid valve of the right ventricle and also the right ventricular outflow tract. So here you'll see different portions of the right ventricle compared to the classical 4-chamber view. And then we have the 2-chamber view, which is similar to the 2-chamber view of the left ventricle, only here you are bringing the right ventricle into the center of the image and you're rotating so that you see the anterior and the posterior part of the right ventricle. This is also a very important view when you want to quantify right ventricle function. So this concludes the apical window, and next on our list will be the subcostal window.